All right, welcome back. This is episode 2 with Jake Marsden. Again, thank you for joining us. We had some great conversations in the first part about just talking with patients who are struggling with this and how you kind of navigate the conversation. But right now, I'm like hoping that we can delve a little bit more into what does a treatment session look like? You know, like, okay, you've had that conversation, you've established that relationship with the patient, but like, what do you do after that first day? Can you tell us a bit more about that?
Yeah, totally. There's definitely multiple ways to go.
Oh, sure.
Here, I think, you know, there's certain signs and like symptoms that you can look for that might clue you in that someone is dealing with more of a nociplastic pain experience, widespread pain, doesn't quite make sense as to the mechanism, or sometimes you get people who are like, I don't know, I had an x-ray and my knee was fine, but it still hurts.
Right.
Or my back was fine, there's nothing there.
Yeah.
So there's little indicators on, you know, we talked a little bit in the first part about like sensory discrimination, testing and training. So, you know, if there's a few indicators, like paradoxical response to exercise is another. Global exercise should activate central inhibition of nociceptive signals. So, you know, there's tests like using pain pressure threshold, where you take the affected area, use a pressure algometer, tell your patient to, hey, tell me when this pressure turns into pain. You record that value, have somebody do some global exercise till sweat, where they should be getting that response, that central inhibition, which would then raise the threshold for how much pressure it takes to turn into pain. Paradoxical response is it takes less pressure than after the exercise. That can be a clinical indicator. And then, you know, let's say you decide it's worth testing. There's a few different ways to do it. Sensory and motor assessments exist. I think for me, the more common one, at least that is impaired, quote unquote, is the sensory aspect of things. So using 2-point discrimination as a measure of tactile acuity. Yeah. That's by far the most common test that I'm doing in the clinic personally. Yeah. And that consists of, you take an anesthesiometer, which is essentially just a caliper with 2 points on it. And you ask your patient to identify whether or not you are contacting them with 1 or 2 distinct points in the area of pain. Yeah. And then there's reference values for what is normal in the population. And if you find that person has an expanded 2-point discrimination threshold, so it's really wide distance, but they feel that as 1 point. That can be an indicator of some, central changes in the sensory motor system that can contribute to chronic pain. So then what do you do with that? Well, if you find an impairment, you can then treat it. Yeah. Do you want me to dive into that right now?
Sure.
Or do you have
whatever you want to dive in? Because actually, on that topic of this is a way you test it.
Yeah, because I'll keep rambling.
Well, yeah, no, hey, I love it, honestly. But is that something you're going to do on the first day, you feel like? Do you often do that on the first day for somebody who presents nociplastic, or are there times when you might wait before you do that?
Yeah, that's not really something I'll do the first day.
Okay.
It's a bit of a, when patients often think PT, they're not thinking wait, why is this person getting out a tool to test? Yeah.
Poke.
So it's a little funky. It's a little different. Which is fine. If it's clinically, if it's supported and you have a good clinical hypothesis, then sure, there's no reason not to do it.
Right.
I think you should do it at that point. But do you have to do it on the first day when you're really, I'd argue the more important thing is establishing your relationship and just listening to the person.
Yeah.
Ruling out red flag, that sort of thing. No, you don't. I think rarely, if ever. But, and you can also maybe this person you're suspecting central nociplastic pain, but then first couple of sessions, you try some exercises or manual techniques and your patient starts feeling better, then fantastic. Keep going down that route. If you hit a wall later and you're like, it's just not quite adding up, like they should be getting better, then maybe you can pull this out and treat. But I think, typically you'll maybe start with traditional exercise and after you then potentially hit a wall or find that you're not making as much progress as you could, that's a good opportunity to test this if you suspect that there may be more of a nociplastic pain mechanism going on.
Yeah, that's great.
It's a great question though, because it, again, going back to like, we can get excited about this stuff.
Right.
Like, I think this would be really good for you. Like I have a hunch, but from their perspective,
you're poking them. It's like what?
Yeah, what am I doing here? And for some people, they might, again, be really interested. For others, and I think, path of least resistance. If you can find a way through exercise and manual techniques to get this person feeling better, then go that route.
Yeah. Because ultimately, it's like you mentioned in part one, it's like patients have their own goals, and oftentimes that goal is just get rid of my pain, please. Like help me get rid of this pain.
Right.
And I think there's a nuance of like, okay, yes, we can like get rid of it in the short term with like this mobilization or this exercise, but like let's get to the root of it.
Yep.
And I think doing those kinds of tests helps you to get a little bit more, particularly if they're more nociplastic. Because obviously somebody could have chronic pain and it's purely nociceptive, but it's just taking a long time.
Yeah.
But nociplastic, that's a little different. It's more than just the timeline. It's how the pain is processed and how it presents, right?
Absolutely. And I don't know that we know enough about like how this stuff works. Like it's
a mystery, honestly, like, in some respects.
Someone may have nociplastic pain experience and they may respond well to exercise. Like going back to what we talked about earlier, like I think everybody's pain experience has some amount of nociplastic mechanisms because it's the brain, and the brain is very plastic and individual and changes over time based off of experience.
Mm-hmm.
So not everyone with nociplastic pain will need tactile acuity training.
Right. And
they may respond well to exercise, and it may even reverse some nociplastic changes. It's hard to know, but I don't think we know, like unless you have an MRI of the person's brain, you're not going to know if that's actually happening, but you can use your clinical indicators, pain and function, and I'd say more often than not, you can probably help with exercise and reassurance and some element of education more than needing to dive into tactile acuity testing. But it's definitely there as a tool that's useful, and is certainly something that I use a decent amount.
Yeah. So, and like going into like the aspect of like, okay, you test this. I think a lot of patients go, okay, great. I can't like feel this is like two distinct points. What do I do about it? Is that something that I can change? Is it something I'm going to live with? Like, how do you kind of reconcile that and help them through that? Yeah,
right. I mean, it's a good question. This is a good, like, how much do you go into it? Education type thing. And it depends on the person again, but I think if you start with, hey, the sensory information from this part of your body, it's not quite being interpreted accurately right now, what can happen then is that the nervous system gets a little extra protective of that part of the body, and it can make that area hurt more, or things that didn't used to hurt might now hurt because the body's in defense mode. And we can see that based off of this test right here. And there is evidence actually that tactile acuity testing, or 2-point discrimination testing, is a valid way to assess tactile acuity.
Yeah.
And there's evidence that altered tactile acuity, impaired tactile acuity, can lead to higher levels of pain.
Yeah.
So, when we are using this, we should be confident in what we're doing.
Mm-hmm.
And anyways, off track, but
that's all right.
Yeah. So I think if you can explain that, listen, sensory information is a little off and it might be contributing to your higher levels of pain. And I think there is an element there's some threshold where there's like buy-in from the patient.
Yeah.
In my limited experience, that's typically once you take that to the training level and do graphesthesia training. Like, for example, that would be taking that value 2-point discrimination distance, trace a box out, say it's this person's low back.
Yeah.
And then you start tracing a letter and you tell them, what did I draw?
Yeah.
And a lot of times that's where people are like, wait, what? You drew an A that felt like a butterfly. Like, and you're, and then they're like, wait, are you serious? And you do it again. And you're like, yeah, no, this is a C. Like, that's a C. It feels like a hexagon. And so like this, then you have a little bit of a buy-in and, you talk about it like, hey, like you remember when you were a kid and people like traced on your back and tell what it is.
Oh my gosh.
And that's you can connect with people on that level and then they'll understand it. And then it's like a in live person, like, oh, I actually can't feel that.
Yeah.
It's a little more tangible than like, I don't know, 2 points. Maybe it's 1, maybe it's 2, who knows?
Right. I think it's helpful just to know like, it's like, yes, what do I do with this information? It's like, because I think it could seem like weird, like, duh, yeah, you drew an A, like, or it's like, all right, we're gonna test like whether like you can tell if this is a B or this is an F. It's like, shouldn't that be easy? Like, let's go with it. Let's try it. Let me know, And I think that's sort of like, oh. And then I think the tricky part then is like, okay, yes, like we've noticed this deficit. How does that connect?
Yeah.
To like how the pain is experienced too. Yeah. Do you find that like how does that kind of manifest? Like as you do that graphesthesia training and as a person's accuracy gets better, how does that kind of manifest in like their pain presentation? Do you notice like sort of like an impact in especially like for patient goals?
Yeah.
Yeah.
I mean, this is all like clinical anecdotal, discussion,
which is fine. Yeah.
Personally, I've seen a lot of success with this. Like if you, if you're suspecting it, that there is an impairment in sensory capacity or tactile acuity.
Yeah.
You test it, there's an impairment. This person has widespread non-specific pain. In my clinical experience so far, there's been some remarkable incidents. And like, of course, as a new PT 3 years ago, I was a little nervous to be like, I don't know, when's it going to work? Like, how do we know? But yeah, I mean, like it sounds crazy, but like oftentimes like you'll get it a couple weeks into this treatment, twice a week, consistent with it. And this, on a brief side note, like when you've identified this as an impairment in somebody, like typically you're doing this as the treatment. And that's what your sessions are, right? Yeah. Maybe you do a little bit of, if there's a functional exercise that your patient really likes and can tolerate well, of course, mix that into, but this should be the focus to lay the like neurophysiological groundwork to build off of.
Yeah.
So yeah, I mean, you'll see, I think clinically, like, retesting, first of all, you'll see accuracy increase in the tracing.
Yep.
We'll be able to perceive it more accurately. I typically do like 20, 25 letters in a session and track the percentage of accurate.
Right. Like we want like above 80%. Yeah.
Yeah. That's generally like one of the numbers that's come out of some like Mosley, graded motor imagery and STT stuff, literature. But once you achieve that, then you retest the 2-point discrimination. And I mean, right there, then you'll see that shrink down, and then you can show your patient like, hey, look, you were here, now you're here. That's pretty incredible. And then they'll like, it's improvement. You can show them that.
Yeah.
And then not with everybody, but with, like I said, there's some remarkable instances where people's pain just comes down. Like, now who's to say, is that part of the education, the reassurance, the discrimination? I'd like to think that when we have like an objective change in a valid measurement of tactile acuity and a reduction in pain, when that's the main focus of your treatment, that they're linked. But I'm sure there's all sorts of error in that assumption, but it's hard until there's some seriously robust evidence on this stuff. It's hard to draw strong conclusions. But when your clinical suspicion is high and there's some evidence to support this stuff, at least in pieces here and there, and you put it together and you're seeing improvement, then it, for the right person, I think it can work. And I think we in the research, we haven't quite fully found, like, how do you fully say this will work for this person? And maybe we won't, but.
Yeah. I mean, a lot of, like, there's some systematic reviews, but a lot of them are like, it works in combination, right? But I think you make a good point where, like, yes, we could do all these things, but knowing which of the multitude of things, whether that's like cognitive functional training, which is kind of like our profession's version of like cognitive behavioral training. Yeah. We're like borrowing from the psychological realm in that regard. Like how much of that is needed versus that grade of like motor imagery or like sensory motor training, the general education about pain science. Like, it's funny. I was talking with another clinician the other day when we were talking about the PRISM model. Are you familiar with that by Joe Tada?
Yeah, I need to refresh myself, but is that has like, was it 16 boxes of category? Yeah.
And I think it was really interesting in how they like talk about the breakdown of like different domains of health, where it expands in the biopsychosocial model of like, okay, yes, like this person comes in, there's probably some domains where they're great. Like maybe they are really strong, but then like their self-efficacy is low. So like musculoskeletally, they might be fine, but like their self-worth, their self-efficacy, maybe their sensory like integration. Like I like that it kind of delves into more of the, okay, you might not need to focus only on this area. There might be other areas that you have to consider, but not everybody needs everything addressed at once.
Right.
You have to identify that yourself.
Yeah. No, it's an efficiency of care type of thing.
Yeah.
And it's, that's why treating the person, like, can you assess these things, these minute breakdowns of this person's experience, and then address those instead of blanketing with exercise. Like, I think that's a big hammer versus a fine, like, needle. Like, how do you, sometimes the hammer will not be as effective, or it might, in, some cases make things worse, right? Like,
right.
You're right. That model does a really nice job of, I think, speaking to some people who have experienced that mismatch.
Yeah.
Like I've done PT to strengthen my knee 50 times and that's not it. And I don't know what it is, but it's not quite that.
It's like, I've been told it's strong and yet I'm told I have to keep strengthening it. It's like, what do I do here?
Right. Right. And that's a scary place to be for someone.
Sure.
I'm sure it's hopeless. And, so this group of people who we're talking about, like, I think this model, PRISM model, and like biopsychosocial in general, can offer a lot of hope to people, especially as bit of a breath of fresh air from being bounced around from place to place to place. And it is interesting because, like, I do think that psychological intervention is a big piece of this. So our friends down the hall in psychotherapy are critical for a lot of this. But there's aspects of psychologically informed care that we can also provide.
And that's a tricky line, honestly. I feel like I remember I was at CSM and that was like a big topic for a lot of people. It was like, wait, like, we're supposed to be able to screen for this, but then kind of treat some of it. Where is that sort of fine line how do we walk that as physical therapists?
Yeah.
And when do we need to get to like the referral side of like, okay, we need to talk to other people to help.
Yeah. I think to touch on that, like if there's a clear, red flag type of indicator, there's ways you handle that. That's where you call in help immediately. But
right.
Other than that, I think it's the patient's decision. I think your job is to screen for it, ask them. Yeah. Like, how are you handling this? If it's already diagnosed, like, how are you doing? How are you handling this? If it's undiagnosed, how do you feel? Like, do you think you need to talk to somebody? I have resources for you. If it's something you're interested in, whether it's now or later, just let me know.
Yeah.
I can provide you with that. But it's their decision.
Right.
In the end. I think with respect to treatment, we can pull psychologically informed care, like motivational interviewing and self-efficacy promotion and that sort of a thing.
Yeah. So we've talked a lot about, like, I feel like whenever you talk about like, oh, these people have been like going around, going through all these hoops, I feel like we both have like people in mind, like when we think about that, like I think about patients I've treated like over this past summer who went through those hoops. It's just like so frustrating.
Yeah.
But I'd really love to hear like what was like a really positive experience you had with a patient who's gone through those hoops. And do you have like a story in mind of like a success story of how working with them through PT has gotten them to a better place?
Yeah. Absolutely.
It's a big question, I know, and I'm sure you have a lot, but just one in particular.
Yeah. I mean, I think a couple jump out to me, but I don't know. Let's go. This is the first person I treated out of PT school.
Really?
Not the very first patient. The first person I treated with this type of intervention.
I was like, whoa.
Yeah.
That's
so
wild.
this was a younger gentleman, like early 30s. He had two young daughters, years of foot pain. So it was like 5 to 8 years, something like that, of bilateral chronic foot pain. He ended up having like multiple surgeries to fuse things and remove pieces of bone and then patch back. And this guy just wanted, like, I remember this, I'll never forget. He was like, not that it's that profound, but it just hit me. He was like, I just want to be able to walk my daughter to school. Whoa. I was like, yeah, man, totally. Yeah,
that's
like that. That's fair. Like,
yeah.
Let's get you there.
Man.
So with him, I think we started with some exercise-based intervention, and it was fine for a couple of weeks, and I thought to myself, like, let's assess this. It's really easy and quick to do. So we ended up doing a graded motor imagery assessment.
Okay.
So recognize that. We can dive into that a little more specifically if we have time, but we also looked at the 2-point discrimination with him. And this was a guy who was very interested in the science. It was something new he hadn't heard before. He'd had a lot of surgery. And so he knew he'd gone through that process of surgery. It didn't help.
Yep.
Now what do I do? So he was very open to hearing about this stuff. So he had impairment in his tactile acuity on both feet.
Okay. We
assessed it, trained it. He was pretty quick. It was like a month and a half of doing that.
Whoa. It's pretty good.
And his 2-point discrimination shrunk down. His pain went down. Once that was all normalized, we started to incorporate graded exercise. I think I mentioned earlier, like setting the neurophysiological like ground to build off of. Like there's a nice quote from Mosley. I forget exactly how it goes, but it's something like where GMI and sensory training is the like essentially the foundation that you have to do before you get to even the simplest exercise.
Gotcha.
To make sure you have that accurate sensory processing and sensory motor organization and building off that. So once we established that, then it was about starting super easy with exercise and exposing him to like load. So you shuttle press with the AirX and socks on. So it's really cushiony and soft.
Oh, nice.
High reps, low load. Use the symptoms to modulate.
Yeah.
Take away the AirX. And then put shoes on. And then go socks. And then go barefoot on the shot. And then so it's gradual. Graded progressions of exercise and exposure. And then this guy, it was so nice. He was able to like play basketball with his kids and run around with them and walk them to school.
That's awesome.
So that was the first time that I did this, and luckily it was a success. I would have been a little upset if like the first time I did it didn't work. I would have been like, oh crap, am I doing it right or wrong? but that's my own, like,
that's great.
my own insecurities about it. But yeah, no, that happened to be a case that it worked out really well for him. And it was really touching to see his progress.
Yeah.
We touched on this a little earlier, but if we can do this early with people and intervene before it gets to a place of nosplastic experience, and they're so sick of it that all right, we have to do surgery. Hopefully this works. And if we can stop that from happening, then amazing. We're saving them years of pain, money, disability, and the system overall as well.
Yeah. That's awesome. I love that story. I mean, it's such a, like, I feel like it's something that you could take for granted. It's like, oh, I walk my kids to school. But like, if you're constantly in pain and like struggling with that, like, oh man, like you want to have fun. You want to enjoy the moment there, and being able to get them to that point, that must have been so special for you. So
yeah,
that's awesome.
My mom also too. She
really,
that was probably the most like personally rewarding, because she dealt with chronic pain for a while and was bounced between, different rheumatologists, et cetera. And then
just telephone. I was just playing telephone. Like, oh yeah, I did this. Huh? Yeah.
I just kept annoying her with this information and like discussion.
Like, Mom, have you heard about this?
Yeah, but then she called me one day. She was like, I haven't been to the doctor in like 3 months. And I was like, oh, cool.
Huh.
And she's like, no, like, I think it actually, I'm like feeling better. We did some of the sensory description stuff.
Oh, no way. You did
all that, but that was like really cool. Like helping your mom like that.
Yeah.
But anyways, it's a great conversation to have. I think it's very important to talk about this stuff, because I think there's a niche, even if it's not fully fleshed out quite yet.
Yeah.
There's a place for this stuff in PT and in healthcare, and I think there's a lot of potential benefit.
Yeah. Wow. That's amazing. Well, again, like we're running a little bit low on time, but honestly, thank you so much for joining us here today. It's really been a pleasure just hearing about your experience, hearing about like just your struggles, but also those success stories.
Yeah.
I think those success stories need to be brought more into the light, and also just how you go about that conversation, because there's so much nuance.
Yeah. Thank you for having me.
Oh, yeah.
You guys are doing good work.
We're trying our best, It's like we're just adding more out there, what we can, seeing if like these kinds of conversations, if we could help people learn more about it, particularly for newer PTs. Like, it's such a, like, I've had like thoughts about this myself. I'm like, what do we do if a patient like that comes in?
I'm sure it's overwhelming as hell if you've never
my gosh,
this stuff, or if you have a limited exposure.
Yeah.
It's a scary thing to try to get involved in, but I think it's worth it.
And yet here you are, just several years into practice, and you already have like a story like that. Like, it's awesome. Like, when did that guy come in? Like, was that like, you said it was like your first patient with that? Like, how far into practice was that?
Couple months.
Wow.
Yeah.
That must have been so intimidating to kind of like tackle.
Of course. Yeah, absolutely.
Oh my gosh. Wow.
But yeah, luckily it worked for him.
Well, just to kind of end things off.
Yeah.
If a patient is struggling with this, like with like a long-term like pain, more than 6 months, several years, like, what do you say to them about like, because I'm sure they have a lot of like reservations about coming into the clinic. Wow. Like, what would you say to them?
Yeah. I mean, well, with respect to generally, like general population, I mean, there's definitely a way to help, one, but I think, it's hard to find the resources of where to look.
Yeah.
But I think it's hard because there's so many places out there that are like pain centers, but maybe don't necessarily provide the best of informed care. It's hard, but I think find resources that feel reputable to you. Like reach out. Like there's absolutely people across the country who know this stuff, and it's becoming more widespread too. So I think, before long, if this hasn't been something that people have heard about, I'm sure it will soon.
Yeah.
But I mean, if you're in the immediate area, feel free to reach out to us, and if you're not in the immediate area, if you want resources, Brian and the crew here can, I'm sure, provide some help. But it is scary, but there is a pathway to potentially helping.
thank you again, Jake, for joining us. And thank you, everybody, for watching, for listening. We look forward to bringing some more videos to the channel soon. But stay tuned, and we'll see you in the next episode. Bye-bye.